So before I dive into the main body of my presentation, I would like to ask the audience a question, which is why would you consider germline genetic testing for BRCA gene mutations in a patient?
You mean with GI cancer?
And yeah. Well, if we don't have the answer, we at least can think of 3 potential implications for undergoing germline BRCA testing. One is in order to be able to evaluate cancer risk in patient or in his/her family members. Second, in order to be able to provide options for early detection of cancer and prevention. And finally, in order to use the germline BRCA mutation as a predictive biomarker in order to provide a targeted therapy. These 3 questions have already been answered for patients with breast and ovarian cancer. We can see in these 2 graphs the risk of developing breast and ovarian cancer in a woman with a BRCA1 mutation. And this, in the second graph, we can see this risk for women with a BRCA2 mutation. And as you can see, these risks are much higher than in the sporadic population. In terms of early detection and cancer prevention, it has been shown that MRI for breast cancer is a very clinically useful radiological imaging for early detection of breast cancer, and it has been also associated with improved survival. Mastectomy is another option for young women at risk of triple-negative breast cancer. And then salpingo-oophorectomy has also been proved to improve survival in women with a BRCA mutation. Finally, PARP inhibitors have finally came into the targeted options for patients with a germline or somatic BRCA mutation, both for ovarian cancer and also for advanced metastatic breast cancer. And we got the results of Olympiad in the plenary session of ASCO all together with a paper in the New England. Nevertheless, BRCA1 and 2 are not the only proteins involved in the DNA damage response. We do have other proteins that are involved in the same pathway, such as CHEK2, ATM, PALB2, RAD50, and also RAD51. And with the evolution of next-generation sequencing, it is very likely that if you order a germline test for BRCA1 and 2, you may also have the option to include these other genes. But we will keep with some other questions. The first is, how often might a BRCA1 or 2 mutation be identified in a patient with a GI cancer? And may a BRCA1 or 2 mutation identified in a patient with a GI cancer help us answer any of the prior questions? Will it be useful for cancer risk estimate, early detection, prevention, or to provide targeted therapy? And what about for the other genes? If we go into the pancreatic cancer, this is a series from Canada, from Ontario, of 306 unselected pancreatic cancer cases. 11% had an Ashkenazi Jewish descendant, which is relevant in all the series that you may read because they have 3 founder mutations, 2 in BRCA1 and BRCA2. So there might be an overestimation of the prevalence of BRCA mutations in cohorts that have Ashkenazi Jewish patients. And what we can see is that overall, 5% of these individuals carried a germline BRCA1 or 2 mutation. And if we select for non-Ashkenazi Jewish patients, the prevalence was 3.8%. In another Ontario series, there were 290 consecutive unselected pancreatic cancer patients. The prevalence of BRCA1 and 2 was 2%. And if we add mismatch repair gene mutations and P53, the overall prevalence was almost 4%. And finally, very recently at ASCO, we got the results of this multicentric cohort of 239 patients. 79% were Caucasian. There was also 10% who had an Ashkenazi Jewish ancestry. And 78% of them had some kind of family history in first-degree relatives. They were all tested with a multi-gene panel, and 11% of them had a germline mutation. 7% in a gene associated with pancreatic ductal adenocarcinoma, and 5% with a gene not associated with a pancreatic ductal adenocarcinoma. And if we go into more detail into these pathogenic variants and the genes that were identified, we can see that in BRCA1 and 2, overall 2.6% of these patients did have a germline mutation. And it was intriguing that ATM mutation carriers were identified in 3% of the patients, and CHEK2 mutation carriers also in almost 4%, despite the majority of these individuals did have missense variants, which clinical utility is at this time not recognized. Interestingly, there were no patients with a PALB2 germline mutation. So some other considerations that I would like you to take into account before ordering germline genetic testing are based on these concepts. One is clinical validity. So we should answer ourselves, what is the risk of developing cancer when we identify the germline mutation? How are we going to counsel these patients and their family members? Are those risks well quantified, and are these risk estimates robust, and have they been validated in large series of case controls? Second, is a germline mutation actionable? And when I talk about actionability for a germline mutation, I mean, what am I going to do if I find a pathogenic variant? And to me, have a germline mutation that is actionable means that the reasonable clinician would make a change in the management based on the test result. And finally, clinical utility, which I define as using the test in medical care that improves a measurable outcome. In essence, that it has been associated with an improvement in early detection or in prevention or in a better treatment. So what about the risk of developing pancreatic cancer in BRCA1, 2, ATM, or PALB2 carriers? We have data for BRCA1 and BRCA2 carriers, and we know that their risk of developing pancreatic cancer is 5 to 10 times greater than sporadic individuals, with a risk as high as 4.5, 5%, and here also as high as 4%. But for ATM and PALB2 mutation carriers, there might be an increased risk, but we are still lacking a robust estimate, and we cannot provide very accurate risk estimations of developing pancreatic cancer in a healthy mutation carrier. What about the utility and actionability for screening pancreatic cancer in a mutation carrier? A very nice study led by our colleagues in the Netherlands showed in 400 individuals at high risk of pancreatic cancer, either because of family history or because they were mutation carriers, with a yearly MRI plus minus endoscopic ultrasound, that CDKN2A mutation carriers were the ones that benefit the most, with a 25% survival at 5 years. Nevertheless, among the 20 mutation carriers of BRCA1, 2, or PALB2, only one ductal adenocarcinoma was identified in a 60-year female with a BRCA2 mutation. It was quite a small tumor, but nevertheless, the patient died 17 months after surgery. And the other two mutation carriers, one in PALB2 and the other one in BRCA2, did have precursor lesions, and they are still alive, but we don't know how they benefit from this surgery and also from this screening. So probably screening at this time, it might only be useful for patients or individuals with a CDKN2A mutation. What about targeted therapy? The first basket trial in germline mutation carriers was published at JCO in 2015. Interestingly, there were 23 patients with pancreatic cancer who were treated with olaparib, 400 milligrams BID, and after gemcitabine refractory treatment, these patients, 22% of them reached an overall response rate. And if we look at this group in more detail, what we can say is that among those who had received prior platinum and were not resistant, or those who had not been exposed to platinum, the overall response rate was 33%. And interestingly, progression-free survival was 6 months and overall survival 13 months. And this was the rationale to actually design this clinical trial, the POLO-1, which is now ongoing, for patients with metastatic germline BRCA mutation pancreatic cancer who are receiving on a first-line treatment with a platinum-based chemotherapy, who have not progressed after at least 16 weeks of a platinum-based treatment, and then they are randomized to either olaparib, 300 milligrams BID, or placebo. And the primary endpoint is progression-free survival. We also have data from another PARP inhibitor, Rucaparib, in this small phase 2. This is a preliminary data that was presented at ASCO 2016 of Rucaparib in patients with pancreatic cancer and either a somatic or a germline BRCA mutation. Patients had to have 1 or 2 prior chemotherapy regimens in the advanced or metastatic setting and had a germline or somatic BRCA mutation. They received 600 milligrams of Rucaparib for 28-day cycles until disease progression, and the overall response rate in these 19 patients has been 15%. What about colorectal cancer? If we go again into non-selected consecutive patients, in this case a series of 450 patients younger than 50 years who underwent multi-gene panel testing, the prevalence of BRCA1 and 2 mutations was 6 out of 450, and if we include PALB2, ATM, and CHEK2, the overall prevalence was almost 3%. Interestingly, 4 out of these 6 patients met the hereditary breast ovarian cancer NCCN criteria, so they had a family history of breast or ovarian cancer, but 2 did not have any personal or family history of breast or ovarian cancer. And this other cohort from the Dana-Farber Cancer Institute, who also underwent multi-gene panel testing in more than 1,000 consecutive patients with colorectal cancer, 33% of them had a family history of colorectal cancer, and the prevalence of high penetrant mutations was 5%, and moderate penetrance mutation was also 5%. Looking this into more detail, from the high penetrant mutations, we can see that most of them belong to the Lynch syndrome spectrum, 3% of them. Almost 1% were genes associated with polyposis, APC, or biallelic MYH. And then BRCA1 and 2 mutations were identified in 1% of colorectal cancer patients. Other high penetrance mutations were in PALB2, CDKN2A, and 1 in TP53. So overall, in this cohort, the prevalence of BRCA1 to PALB2, ATM, and CHEK2 mutations was around 2.3%. And what about family history in these patients? So we can see that 73% of the BRCA mutation carriers actually lacked clinical features of hereditary breast ovarian cancer, so they did not have any family history. And none of the 2 PALB2 mutation carriers also had a personal or family history of breast or ovarian cancer. In addition, if we consider that the BRCA1 and 2 population prevalence is between 0.25%, 0.65%, which means 1 out of 200 or 1 out of 400, and among colorectal cancer patients unselected, the prevalence of germline mutations is 1%, this is absolutely hypothesis-driven, but at least it raises the question and the point of whether BRCA mutations might be some genetic susceptibility for colorectal cancer. And one may consider that knowing the clinical utility of identifying a BRCA germline mutation, if we should include BRCA testing in patients who are undergoing germline testing in colorectal cancer. So having all this in consideration, in our Catalan Cancer Network, we agreed for the following hereditary cancer panel. For patients with colon and endometrial phenotype, we offer the opportunistic screening with BRCA1 and 2 and all the mismatch repair genes for patients who have a personal and family history of colon and endometrial, who had been diagnosed with colorectal cancer below age 35, or who have a risk of hereditary pancreas because of the family history or a very young age. And in this customized panel, we add PMS2, EpCAM, MYH, POLD, and POLY in the colon endometrial phenotype. The same ones plus TP53 in young patients with colorectal cancer, and PALB2 ATM plus CDKN2A or CDK4 if there's a phenotype or a family history suggestive of melanoma. And finally, something else that we are now encountering and which is also quite challenging is to identify the origin of the mutations that we identified through tumor sequencing. If we look into the bioportal database, we can see that for BRCA, PALB2, ATM, and CHEK2, the prevalence of these mutations as being completely somatic in colon cancer cases is around 5%. And among pancreatic cases is around 2%. But should we rule out if we don't know if there has not been subtraction of the germline analysis? Should we refer these patients for germline confirmation? I think that any BRCA mutation that you identified through tumor sequencing should be referred to a clinical cancer genetics to rule out if the origin is germline, and in order to provide the opportunity for cascade testing in family members. If a founder germline mutation is also identified, such as the one in CHEK2, the lesion 1000C, or the BRCA1 and 2 Ashkenazi Jewish mutations, also should be referred for germline confirmation. Pathogenic variants in all these DNA damage response genes should be considered for referral. And as always, patients whose personal or family history is suggestive of a hereditary cancer syndrome should be referred regardless of the somatic testing result. I mean, despite the somatic testing is negative, since it has not been performed in order to identify germline mutations. And how this disclosure of germline genetic testing should be done. I would recommend to have a germline expert board that meets periodically and that discuss the clinical significance of abnormal findings, and with people who are able to contact patients with likely pathogenic or pathogenic variants. This germline expert board should include genetic counselors, clinical geneticists, the medical oncologists, and the molecular pathologists, and they should be able to disclose the findings to the patient or designate the next of kin or the closest family member, be able to review the personal and family history, provide genetic counseling with all the potential implications, and finally, perform and recommend germline testing in family members. The importance of genetic counseling in hereditary cancer comes from the opportunity to take a very good family history, to be able to understand and to explain the medical implications, psychosocial prevention, early detection in the family member, reproductive options as well, being able to understand and listen the patient and their needs, and being able to enhance the communication skills in the family in order to promote cascade testing. So in conclusion, my take-home message from my presentation today would be that germline testing of DNA repair genes has several implications in terms of providing cancer risk estimates, early detection, prevention, and targeted therapy with the development of PARP inhibitors, that the lack of family history does not exclude the risk of a hereditary genetic cancer susceptibility, that the germline BRCA1 and 2 mutation prevalence among unselected colorectal cancer and pancreatic cancer is low, between 1 and 3%, but it may carry relevant clinical information and implications for the patient and his or her family members, and it is worth to pursue if the origin is germline. Next generation sequencing technology is allowing panel testing of several genes in parallel, and we have to consider and respond each of the questions that we made about clinical validity, actionability, and clinical utility before we validate and perform and offer genetic testing for these other genes. And finally, the targeted therapy-driven germline or somatic testing is likely to increase the number of mutation carriers identified. And I believe that this is becoming an opportunity for cascade genetic testing in relatives who may benefit from individualized cancer surveillance and preventive options. Thank you.